I guess he went to the wrong building, but he'll be here just shortly. But Linda, did you have anything prepared that you wanted to talk about? Just kind of an update on where we're at.
Good morning, Commissioners. Linda Oaks from the Health Department. No, but
Okay.
I can
All right.
I can give you a short update on what's happening at the Health Department. So we have had fewer cases, as you're going to hear about, so we've been able to get all our cases assigned every day. Biodefense continues to do the great job they've been doing, and our staff have been having some breaks, so including myself, so we're all just a little happier over there that we've had some vacations and time off. So we are in the middle of hiring some more folks, as you know. We have an epi opening, and we'll be looking for that team leader that you approved today. So really, things at the Health Department do feel a little more kind of almost back to normal. I hate to say it, but we're getting ready to do some of our normal tasks. So that feels pretty good.
How about immunizations for school-age kids as they're going back to school? Have we seen quite an upswing and all that?
We're seeing some more. I wouldn't say a whole lot, but yes, people are calling, and you can still call and make an appointment for immunizations. Anyone that has Medicaid vaccine for children eligible, or if your primary care doctor doesn't do vaccines, then we can get you in. We'll also be starting flu shots here pretty soon, so stay tuned for those announcements.
Okay. So,
and here's Dr. Pizzino.
Oh, okay. Great.
Thank you.
I might just say, one of the reasons I wanted to have a health meeting today is, well, we're still in the middle of a pandemic, I guess. So with schools opening and we still have businesses that are restricted, I thought it was a good idea that we get together and get an update on where we're at with that and where we're heading. And so Dr. Pezzino, you like to fill us in a little bit on where we're at?
I can give you some numbers. First of all, my apologies for being late. I diligently went to the courthouse for this meeting instead of here. So, yes, I have a few numbers here. I don't have any specific numbers about schools, if that's what you were asking, but we can certainly talk about it. I do have some information. And this should be really quick because I don't have a lot of slides. By now, you are familiar with this slide. That's the number of cases per week, with the day indicated in the horizontal axis being the first day of the week. As you can see, we experienced a decrease last week, which is good. And so we are still watching to see if that's the beginning of a trend or if it's something that will last only 1 week. We hope not. An interesting question every time we have a decrease in the number of cases is whether there was less testing. In fact, there was more testing last week than the week before. So that's a good thing. It means that decrease in case is not an artifact of the number of testing. And so as a result, what that means is that our percentage positive last week dropped dramatically by about half. Probably the question that's going through your mind is the same question that went through my mind when I saw this number is why? And the true and honest answer is we don't know for sure. We do know that we have seen a decrease in number of cases, especially in nursing homes. And we also know that there were some laboratories that were lagging behind a little bit in reporting the results, in part because of the long weekend. These may all be factors, but in reality, we really, sometimes we miss why these numbers go up and then go down in this way.
Well, in the testing, was most of the testing in nursing homes and places where we had clusters, or is this just overall testing?
That is part of that. The number includes all the tests done on Shawnee County residents. Okay. All the tests done by hospitals, by private physicians, by private labs out of state, and so on, as they are reported into the state disease surveillance system, which is called EpiTrax, then it would be included there.
And what's the turnaround time on testing now? What are we looking at?
That is still a sore point. Again, it varies up and down quite a bit. As I said last week, some labs were lagging behind. I think this week is going a little better. I would say in general, on a good normal day, a couple of days. Keeping in mind that there are some different tests that can be done at the point of care, so like in the emergency department or at the doctor's office, those can give you results in 15 minutes. Unfortunately, especially when those tests are negative, they're not as accurate as the gold standard, which is a PCR test that typically we perform with a nasal swab. So this is a pie chart that shows how our cases last week were split into 3 categories in terms of their source of exposure. The red category is known, the blue is people unreachable, and the green is unknown. So the difference between the blue and the green is that in the green, somebody was able to talk to the patient, and even after the interview, we just didn't know what the source of that infection was. The blue group is the one that concerns us quite a bit because it's going up, it's growing in size. That is a group of people that simply refuse to talk to our investigators. And as you probably recall, that's their prerogative. It's something that the state legislature specifically included in their bill at the beginning of June. And so what we are required to do is to disclose to them at the beginning of the interview that they are not required to talk to us, and if they prefer not to talk to us, they are free to do so. And you can see about 30% of them last week elected not to talk to us. So unfortunately, that puts us in a conundrum because without that information, we can't really track how the infection is spreading. I hope that by now, many of you, if not all of you, are familiar with these charts. That's what we call our scorecard, and it's updated every Thursday. So the scorecard for last week is being issued as we speak or around noon. And we look at 6 different categories or indicators, and for each of them, we classify their values into 1 of 4 zones, going from green, which is the lowest, to red, which is the highest. And then we develop a summary index score. The week before last, we were at 16, which was pretty high, which was actually borderline with the highest level, the red level. This week, in part because of the drop in the number of cases that I showed you earlier, we dropped to 9. So it's a substantial decrease. We were pretty close. We're just 1 point shy of being into the yellow area, which is exactly what we want to see.
When it says uncontrolled, what's uncontrolled? Is it the transmission that's uncontrolled, or is it
yes,
the
essentially
ability
what
to
that means
track
is
it?
that the transmission is uncontrolled and the tracking is not effective because there are so many cases. So typically these are situations where at the community level we see several clusters popping up in ways that are apparently unrelated, and we see also several individual cases that pop up in ways that are unrelated. The problem is that when we have a lot of cases in the community, it's really hard to make sense of all those different pieces of the puzzle, and so that becomes uncontrolled. And again, these are definitions that are provided by the Center for Disease Control. We just borrow those categories from them.
I think sometimes it's hard for people to understand when 1.3% of our population have tested positive, how that could be uncontrolled. It seems like a very small number.
I'm going to show you some numbers.
Okay.
I won't disagree with you. It is a relatively small number. It is a number, though, that affects our community pretty heavily, just because of all the control activities around the number and the effort to keep the virus outside of high-risk populations like jails and nursing homes and other institutions. So these are some of the other numbers. And by the way, these numbers are all available on our website or on the KDHE website. And I know that some of you had an interest in seeing them displayed in one chart. So the case rate can be considered as the intensity of the infection in our community. So since the beginning, we have had a case rate of 14.3 per 1,000 people resident in Shawnee County. Of those cases, 23 cases, of those 157 were hospitalized. That represents 6.2% of all cases. The hospitalization in young people were very low. We only had one below the age of 19. We had 28 deaths. We do not show the breakdown of the deaths by age group because numbers are too small and we run into confidentiality issue, but I can tell you that all the deaths were in older adults. Not necessarily old people, but we have not experienced in Shawnee County any death in young people as of today. Out of those 2,523 cases, 1,961, or 78%, completed their isolation. What does it mean? It means that essentially they are out of their acute phase. We used to call this, and I think our dashboard still has the term recovered. We are going to switch to completed isolation because of the growing evidence that a lot of people, even though when they come out of isolation, they're not fully recovered yet. And some people report still symptoms for months and months after they're out of their acute stage. So are these numbers high? Are these numbers low? You know, it's to some extent, that's a judgment question that each of us may answer in different ways. To give you just one little perspective, the case fatality rate, so the proportion of deaths out of the cases that were diagnosed, is about 1%, which is about 10 times as high as the one for seasonal influenza. You can look at the other side of the numbers and say, you know, you only had 28 people who died. I assume if you're one of those 28 families that lost their dear one, probably that's not a big consolation. But it is true that some of these numbers are really not very high. I also want to remind you that this is the result, I have no doubt, there's no doubt in my mind, this is the result in part of the containment measures that we implemented in our county. So had we not done what we have done, those numbers would be much higher. But one of the challenges that we have as public health officials is that sometimes we have to adjust the heat, as we say. So what that means is that there are situations where people are just not listening enough to us, so we want to turn the heat up a little bit. And there are other situations where people are listening too much to us, and we want to turn the heat down a little bit. And we've done both in the last 6 months. And I want to go back to my very first presentation on March 2nd in front of this board about the coronavirus. People were getting really worried. Businesses were starting to close. And at that point, we were starting to receive pressure from people to enforce a lockdown in our county. And we didn't think that was the right time quite yet. In fact, we waited for, I believe, another 10 days after that date. So our attempt at that point was to turn the heat down and tell people, look, this is serious. We are taking it seriously. You should take it seriously. It's not a death sentence. It was already clear back then that most people will recover. So, you know, the message was don't panic over the coronavirus. When you fast forward to more recent weeks or months, I think we find ourselves a little bit in the opposite situation, where there is certainly a virus fatigue and people are, in some cases, reluctant to continue using the same precautions that we have been asking them to use for months and months. especially when they don't see an end point. So I want to talk, and then I will stop for questions. I want to talk about the end points for this. And I want to do that by going back to our scorecard. One of the reasons that we developed this scorecard is to give us a pathway towards public health policies. The measures that we have in place now, the precautions we have in place now are adequate for an orange category of transmission. If we went into a red category, we would probably need something more. If we go, and when we go into the yellow category, we may not need all the precautions that we have. So our guideline at this point is the scorecard. And what we want to see, we are not going to act on a 1 week change, because that's too soon. We just don't know if it's just a statistical glitch or what it is. But we want to see 2 consecutive weeks in the yellow area. And then we would like to start having a conversation on what precautions maybe are not as necessary or as important at that point and can be removed. So we need to exercise flexibility, and this tool really gives you that flexibility, hopefully in both directions. In both directions, meaning that should we lift some restrictions because we are 2 weeks in the yellow and then we go 2 weeks in the orange, we may need to go back and put some restrictions back in place.
Dr. Pizzino, why is, in your scorecard, you don't have the recovery rate? That's not a factor of what our recovery rate is for this virus? Because I'm figuring the recovery rate at somewhere around 98.74 for those.
I don't think that would be very helpful for us, Commissioner, because that remains pretty much stable.
That what?
Remains pretty much stable over time. So what we are looking for are measures that are sensitive to time, to changes in time. They can give you a sense of how widespread the outbreak is. That recovery rate is something that's probably not going to change dramatically over time. So it's interesting to know, to understand the full epidemiology of the disease, but it wouldn't give us a lot of information to guide us in deciding, do we need to put more restrictions or fewer restrictions in place?
It's a number I never hear out there. It's never on our dashboard or anything.
Actually, it is on the dashboard.
It is on our dashboard?
It is. Well, there is a number. It's not a rate. There is a number, but you can make a simple division to get the rate. And by the way, I want to make a comment that we do realize the dashboard has shown some limitations over time. The dashboard was started at the very beginning when things were a little different. So it's one of our priorities to, we are already working on it actually, to make some changes to the dashboard to make it more helpful. So if this is our guidance, as I said, we had just a drop in our index score that still leaves us in the orange, but it was a substantial drop. So at this point, we're not going to make any big changes, but there are 2 changes that I want to announce here that we have already decided and put in place. Number 1, we are allowing nursing homes to go back to following the federal reopening plan, the CMS plan. And that plan has 3 different stages. And stage 1 is essentially full lockdown for the nursing homes. Stage 3, visitations are allowed, and stage 2 is somewhat in the middle. You may remember that about 4 weeks ago, when we started seeing so many outbreaks in nursing homes, we asked all the nursing homes, regardless where they were in the plan and whether they had cases in their own facility or not, we asked them to go to phase 1, to stage 1 of the federal plan. So all the nursing homes were in lockdown, essentially. And we understand how hard that is for our senior citizens. So we just sent a communication yesterday saying that they now should follow the CMS recommendations, because the situation in our nursing homes in Shawnee County has improved. And so there are still some with cases, and those will still have to have some limitations, but those who do not have cases, have not had cases in the past 28 days, can reopen.
Would you say the majority of our cases is in nursing homes or other clusters?
Couple of weeks ago, I don't know if it was a majority, but a fairly large number, and possibly the majority, honestly, I didn't count them, were in nursing homes. Also because nursing homes were doing screening when they have a case, they follow certain protocols, and so they screen all the symptomatic residents and workers, and so they are finding new cases. That number has gone down considerably now. So that's the first change we have introduced. The second change is that at the same time, I think it was August 22nd, if I'm not mistaken, we advise all the people with high risk of complications to just stay home. And now we are telling them that based on the new data that we have, we recommend that they still exercise caution, but we don't recommend that they just stay home and don't leave their houses. I think they need to perform their own personal risk assessment, try to avoid particularly crowded situation, especially indoors, and try to exercise social distancing, but we do not consider necessary for all the people at high risk to just stay home at this point. That's really all I have, I believe, for you, yep, and I'll be happy to take any questions.
I know a lot of businesses are concerned, about their capacity that they can have in their stores or their hours. When do you see that loosening up?
Are you talking about nursing homes?
No, I'm talking about just businesses, right now a lot of them are working at 50%, well, restaurants.
Oh, I see what you mean. Commissioner, what I would like to do, I really don't want to lock ourselves now into deciding what is the first thing we are going to remove, and then the second and the third. And the reason is that it may depend in part on the epidemiology of the infection at that time. So as I said, the prerequisite is that we go through 2 weeks in yellow. At that point, then we will look at our data and say, well, where are our cases coming from? If most of them are coming again from nursing homes, then maybe we can look at places like restaurants and see if we can relax some of those requirements. If many cases are linked to restaurants, then we wouldn't do that. So it will really depend on the situation, and also we wouldn't want to lift too many measures all at once. We would like to take an incremental approach so that we can monitor the effect of those decisions. But everything is on the table, and as we have said multiple times, it was never our intention, it still is not our intention, to keep the emergency public health order in place forever. That's just a tool to decrease transmission. Once we reach a level that is manageable, which for us is somewhere in the middle of the yellow area in a sustained way, then some of those restrictions, if not all, can be lifted.
I think one of our issues, or one of my issues right now, is the perceived risk of this virus. And I think between health departments across the nation and media, we have just scared people to death. There was an interesting poll taken where they asked the average American, they said, how many people have died? And the average number people are coming up with was 30 million people, and it's less than 200,000. So where have we failed in the message? Where have we failed? I mean, that's terrible that they're that far off. I even talk to people in Shawnee County. I say, well, how many people do you think have been infected? No, they're going thousands and thousands. They have no idea. And I just think we aren't displaying the risk very well. And that's something I would like to say. Like, as an example, as kids go back to school, that age group from 5 to 17, the hospitalizations for that age group is what?
It's very low.
It's like 0.004, something like that. It's even less when you're a little, that's from 4 to like 10. You go from 10 to 17, it's like 0. There's just like nobody there. And I think that'd be good information for people to know when they're sending their kids back to school. And then even parents' age, if you look at age group from 25 to 45, which would be most of the parents, it's still the the percentage rate of getting the virus and your survival rate of it and your hospitalization rate are extremely low. Now, there's always going to be a case. There's always going to be somebody who has pre-existing conditions. There's people that are vulnerable, that have to be protected. But I think people would feel better about sending their kids to school. I think they'd feel better about going back to work. I think they'd feel better about a lot of things if we presented that type of risk percentage. And I'd like to see that in our dashboard. Say here's your percentage chance of being hospitalized at this age.
Commissioner Rippon.
Yes.
This is a common thing that you've mentioned in the past, and
Yes.
Something that I've thought about a great deal. Do you recall when you were in high school learning to drive, having to watch a movie, probably on a projector, called Blood on the Highway, telling you the dangers of traffic? If we look at the United States, in 2018, the death rate was 1.42 per 10,000 vehicles. That was a 98% improvement from the high in 1933, which had a 12% or 12 death rate per 100,000. What was the improvement? A lot of it went into safety, a lot of it went into design, a lot of it went into education, but also a lot of it went into seatbelts. A piece of cloth that restricts you is cumbersome, but is also a protective device. And I think part of this is education. And if you want to talk about where I think we have failed in education. The four basic simple: wash your hands, maintain social distancing, do a risk assessment, wear a mask. No different than in your car. Do a safety assessment of your vehicle, make sure it's a safe vehicle to drive at a reasonable speed. Don't put yourself into a situation where you're taking risky behavior. Wear your seatbelt. That's the advice that we give every new licensed driver, and I think that's part of our education for our students coming into the schools. Is these are, yes, it is survivable. Yes, we have a lower risk for younger people, but it's not a zero risk.
You know, I'm glad you brought up the car, because we could require people to wear a helmet, wear a fire retardant suit, put baffles in the gas tank so they don't explode. We could add more steel. We could make the speed limit 30 miles an hour. We could tell people to stay home on weekends, not drive after midnight. There's a lot of things we could do and reduce that almost to nothing. But we have to look at the risk involved. Everything has a risk. Right now, the risk of dying from this virus is about the same in Kansas as dying from a car wreck. Almost exact. We're on that same track. We get in our car every day, we back out of our driveway and take off for work. We're willing to assume that risk. Are we willing to go back to work? Are we willing to take our kids back to school knowing that the risk is about the same as dying in a car wreck? It's a risk assessment.
Every time I go out to eat, every time I walk into a store, every time I interact with the public, yes, there's a risk.
That's right.
But I think that, we go back to education, knowing what the factors are, and I think that's the role of the health department, is in that education. And I want to thank Dr. Pizzino for a lot of what he does is going out and talking to the public and engaging them in in that discussion, answering a lot of questions.
And I think, Commissioner Rippon, I agree with you that the risk is not even for everybody. It's not the same for everybody. And I would also say that perhaps we can do a better job showing those differences. So for example, we don't have a lot of data by age group in our dashboard. That's something that I would like to change. Please keep in mind that the data sometimes are hard to get, and there's a lot of different issues there, but that's a direction we want to move towards. One caveat is the big difference here between, say, wearing a helmet on a motorcycle or a seatbelt in a car and wearing a mask is that the first two examples, the protection is for the person that makes that decision. In the second example, for the coronavirus, the protection is primarily for the people around. And just because children don't become very sick and they're not hospitalized, it doesn't mean that their rate of infection is inconsequential, because they go back home. We don't have social bubbles. We have seen that in nursing homes over and over again. How our outbreaks started in the nursing homes were from staff. Now, I'm not trying to point out, any fingers or to shame anybody. Is that people have lives, and as much as the nursing homes are trying to insulate and protect their residents, when the workers go home, they have their own life, and when we have a lot of transmission in the community, then those workers may become infected and bring infection into the nursing home. Same things with children. So yes, children will not get very sick usually, although Dr. Cooley, as you may have heard him talking, is very passionate about showing that it's not a universal rule, that some children do get very sick and even die. But granted, it's not at the level of somebody with underlying conditions who is 75 years old. The problem is that children can bring the infection to those groups as well. So the challenge is, how do we keep those groups separated? So bottom line, Commissioner, yes, we will try to do a better job to display different levels of risk at the individual level, but I also want to be clear, and going back to the educational component, that those categories, those age groups are not insulated from each other. They mingle, they communicate, they're part of the same extended families, and so the last thing we want to see is a an elementary school kid go home and infect grandma and then have severe consequences in their grandparents.
I've always said we need to protect the vulnerable, and there's always those cases. And I wanted to talk just a little bit about the upcoming other flu that's coming along. Every year we have a flu that comes along, and the new one, we do have a vaccine for it. Is that correct?
Yes, there is always a vaccine for what we call the seasonal flu, the one that comes every year. Some years it's better than others, because that's really, it's an interesting virus because it mutates every year. There's some changes, and so the vaccine that is good one year will be only partially good or not good at all the following year. So every time there is a kind of a cat and mouse game between researchers and the virus to see, how quickly can we guess what the virus will look like so we can develop a vaccine. The vaccine is already here, and people can already get vaccinated. Usually the vaccination campaigns start really in October, and then they continue throughout the season. I can tell you, and it doesn't mean that the same thing will happen here, but in the southern hemisphere, which is where winter was during our summer, their flu season this year has been mild. And people think that it's in part because of the social distancing that communities are practicing because of the coronavirus. So it's a kind of positive bonus and side effect, if you will, the social distancing. Is that going to happen also here? We hope so. To be brutally honest, I'm afraid that people don't practice social distancing in many communities in the United States as much as they do in the southern hemisphere. But that's our hope. The main message for everybody is we do not have a vaccine for coronavirus yet, but we do have a vaccine for the flu, for influenza. So do and get that vaccine. It is more important than ever this year. Number one, you do not want to get both viruses at the same time. Believe me, you don't, because they attack the same organs to some extent. And now you have your lungs attacked by the coronavirus and the flu vaccine at the same time. No good. The second problem is that you can't really tell apart somebody with symptoms and decide, okay, this is a case of coronavirus, COVID-19, but this is a case of influenza. The only way to do that is through laboratory tests. And so if we have many more people showing up with symptoms, we have to test them. And that will put even more pressure on the testing system than what we have now. It will lead to more delays. And so it's really extremely important this year for everybody to get the flu vaccine. It's not perfect. It's usually at least 50%, if not greater, of effectiveness. And typically, the effectiveness is not all or nothing. So even people who may get the flu after they are vaccinated, usually they develop mild cases. So there is a gazillion reasons why the flu vaccine should really be at the top of the list for everybody in this community.
So if we have a vaccine that they say is kind of on the horizon for COVID, can we expect any better than 50%?
That's a big question everybody's trying to answer.
Yeah.
The FDA has already said that it will not authorize a vaccine that's below 50%. Whether it's going to be much higher, 50%, or at 50%, frankly, I'm not even sure that we will know that until the vaccine is really deployed.
The other question is, when this vaccine arrives, do we have a plan for who gets the vaccine first? Are we hitting the vulnerable people? Are we hitting people who are in confined areas, like say a jail, or are we looking at healthcare workers or first responders, or who?
Yeah, those
what's our
plans are
plan?
under development. I don't know if Linda wants to add anything, but they are under development as we speak.
Yeah, I can talk about those plans a little bit. So the Kansas Department of Health and Environment is already getting their plans in place. So they will let us know who the priority groups are. And is what I have heard so far is that we're looking at frontline healthcare workers, people with high-risk underlying health conditions would be in that first group. I think it'll be a lot like H1N1 was done several years ago. So they distribute the vaccine to us, we distribute it on, we give it to partners as well as administer it ourselves. And so I think it'll be a combination of us and other medical people giving that vaccine, much like we did during H1N1.
Mr. Mays?
Do we at Shawnee County have any say in that at all, or is that all prioritized under guidance from the feds and the state?
That's a good question. I believe we will most likely follow the priority that's given to us by KDHE. I mean, they work with the federal partners and they set how it's given, and so yeah.
Okay, and the reason I ask is because when you say that they're probably going to give it to frontline health workers, you know, they have the appropriate PPE typically, but there are people that have a lot of contact with the general public that don't necessarily have the appropriate PPE. I think of teachers. You know, we talk about schools, and the infection rate in children is not that bad. And as a parent of school-age children, I'm not so much worried about my kids going to school, but, you know, the staff at the school. You know, what happens if they have to quarantine or whatever. But, you know, I think if we do have any say, I would prefer that teachers and folks like that maybe be prioritized as well. So
It's never easy decisions. It wasn't easy during H1N1. It won't be easy this time, I can tell you that.
yeah, thanks.
All right.
Anything else I can help you with?
I just want to make a comment. I noticed a federal judge, William Stickman in Pennsylvania, this is on the 14th of this month. He said the Constitution cannot accept the concept of a new normal where the basic liberties of people can be subordinated to open-ended emergency mitigation. Now, that's quite a statement. He's saying we can't be locked down in an emergency situation forever, that we have our basic freedoms that we have to, so.
Mr. Chairman, if
Yes.
we're going to get into the legalities of that, I mean, I think that our counselor, I mean, I think if there was anything that we have run, I mean, I think all jurisdictions, every community, every county, every state is walking what are the boundaries, and in some cases, we have laws that are being made in special sessions and changing the landscape. I know Jim's staff and the county councilor is constantly researching the legalities of our actions to make sure that we are there. But I agree that, you know, this is a balancing act of our freedoms.
Just reporting what happened here recently, and I think it's relevant, so, anyway. Any other questions or comments for Dr. Pezzino?
I have a couple.
Sure.
Could you go back to the scorecard? A couple of questions on the scorecard itself. And we've talked about this before, so I don't think this is any big surprise to you, but the percentage of new cases with no known source of infection, and the slide that you had showed before this one had 30% of people that were unwilling to cooperate. With that 30% of people that are unwilling to cooperate with the contact tracing in any way, shape, or form, does that enable us or inhibit us from ever reaching the green in that category?
That's a good question, Commissioner. I don't think so. Now, I don't have the table with the different categories in front of me, but I believe anything below 50% would be considered as green. So we are not even close to that point. You know, I've been thinking about this, and I understand that's not a perfect indicator, where none of these are actually, but perhaps that's even more imperfect than others, because it's affected by a variety of factors. Some of them are outside of our control. At the end of the day, though, the way I decided, at least for now, to leave this indicator the way it is because for practical purposes, for whatever reason, whether it's because people don't pick up the phone or because they give us the best history that they have, but even with that we cannot identify the contact. For whatever reason, we still have so many cases that we don't know where they acquired infection. And that's really what matters from the public health point of view. But I do recognize if the number of refusals go up to a point where it's 50% or more, boy, I hope not. But if we get to the point, then you're right, we will never be able to get to the green. Then maybe we should ask ourselves, is that the right measure or not?
I would appreciate it if at some point we maybe continue to just keep an eye on that category, because when you look at the current, the new scorecard that came out, it appears to be the outlier pretty much every week. I mean, it's been in the red, and I mean, perhaps just the criteria maybe need to be adjusted in that one to make it more indicative of exactly how many were.
Right.
But so, and then the other thing I wanted to ask on the category there, the public health system capacity stress, how is that being measured? Is there a quantitative number that you're coming up with
Yes,
based on
there
criteria?
is you may or may not recall, it's a kind of nested scorecard system here, but there is a separate scorecard for public health capacity. And in fact, that's the one we first introduced about 2.5 months ago, I believe, something like that. And that's just purely the capacity of the public health system to cope with the number of cases. So how long does it take to reach out a case? How long does it take to enter that information into the system and so on? And that's also, it also has a yellow, red, and green. And so depending how many red areas we have on that card, they will be scored accordingly on this one. We are in the process of making some changes to the card, because again, it was developed 2 months ago, and now we can fine tune it. But I think it's probably the best measure of capacity that we have, rather than just taking one element arbitrarily that probably will reflect only a partial capacity for certain things, but not for others. And so as soon as we have that completed, we should be, a matter of a few days, we will definitely release it to you and then to the public, so people can see both scorecards, essentially.
Okay, and then one other thing, more of just a comment. I just kind of want to commend the health department in their ability to kind of scale this. That I remember at back in April and May, I mean, we were very overwhelmed when we had 20 active cases, and we're now up to 500 active cases. And we're no more overwhelmed now than we were then. We've adapted very quickly to the circumstances, and I commend you guys for being able to do that. Thank you.
Sure. I think flexibility is really the key in this situation. You had a question?
Yeah, a question on the hospital occupancy. I don't have the latest one. I have the one before that. Mine says 77.6%. Now, that's not COVID cases in the hospital. That's total
Right.
occupancy of the hospital. What is the percentage of COVID cases in the hospital? Do we know that?
It varies quite a bit. I can't tell you the percentage, I can tell you the absolute number, which the last few weeks has fluctuated between 25 and 30 at any point in time.
Total.
But it's a very small proportion. of
But
cases.
percentage-wise, it would be
Very,
below
very small. Very small.
5%
But
or
the
less?
reason we use this particular measure is because hospitals are there to take care of all the needs of the population and not just COVID-19. So if we were, let's say we have a very bad flu season and a lot of people hospitalized for flu, then we have very few beds left for COVID-19 patients. So that's helpful information to know as a measure of stress on the healthcare system.
I was wondering how that compared to last year, what their percentage of beds that they had last year.
Yeah, that's an interesting question. I don't know. But
Yeah, and I wonder if we're not at a higher capacity because people are afraid to come in to see their doctors. I mean, we know that we have a lot of people at home. They're not coming in to get cancer treatment, or maybe they've had a mild stroke. They're not coming in. They're afraid to come in, and that's going to be a bad situation across
right.
the country.
I think that I have no hard data on that. I think that was more true a few months ago. But typically, hospitals like to float in that area between 72 and 80% of occupancy. They want to have a little bit of surge capacity. In fact, some people will say that surge capacity of 20-25% of beds is not enough, and we need more. But there are obviously financial reasons that become barriers. So at this point in time, I haven't heard anything from our hospitals that they see people delaying care, but that was definitely a problem a few months ago, well, if nothing else, because hospitals wouldn't allow people to come in for elective procedures, and so all the emergencies were taken care of.
Are we going to do anything in the way of public address ads telling people, it's safe to go to the doctor, come on in, if you need to? Because we still have people that they're afraid to come out. There's a lot of elderly and.
Yeah, that can definitely be part of a communication campaign. I mean,
to me, we may have more problems with people who stayed at home than we have of deaths from COVID. It could very easily happen, and so I'm concerned about the people that are at home and aren't coming out. Okay. Any other questions?
I've got one more thing I wanted to mention, and I think that, and I've spoken about this with several staff members, that whether real or perceived, I feel that some of the communications that we get from the general public have indicated that people feel that oftentimes you make your decisions in a vacuum and that you're not consulting with other professionals and whatnot. So I've kind of thrown out the idea with some of the staff members that we create an advisory team similar to what we do with the Parks and Rec Advisory Board, which would be sort of a public health group of medical professionals and appointed folks that would maybe consult with you on a regular basis to kind of go over some of these questions that we're talking about today. More subject matter experts to help you make these decisions when doing health orders, but then also extend beyond COVID when we get to our county health rankings, when we talk about obesity and tobacco usage in our community and things like that. Just so you guys know, that's something that I've thrown out there. I hope that we'd be willing to have that conversation at some point.
And as far as I'm concerned, I would be fully supportive of that idea. And Linda and I have been talking about some draft concepts that we will send to you very soon.
Thank you.
All right. Anything else? Well, Well, thank you. I guess we're adjourned. Thank you.